This conference will now be recorded.
Bismillah ar-Rahman ar-Rahim. Hello, all my colleague, all my friend. Today, inshallah, our session about gynecology and oncology problem. I hope that you all are fine and doing well in this difficult time. Take care of from yourself and from your family. And at the same time, you have to do all your best to pass this exam, to finish this story. And as I said before, the best thing to do to finish this exam from the first attempt. So try to do your best. I think all of you now have a lot of time while we are all standing at home, sitting at home after finishing your duty in the hospital. So try to get benefit from this time. You will find suddenly that everything, inshallah, will be opened and everything will be as before, and you will find yourself in front of the exam. So the one who he's wasting his time now, and the one who win, who take benefit from the time and study hard, not waste his time. As I said before, try to read the patient information leaflet every day. Try to read 1 or 2 patient information leaflet and keep recording this patient information leaflet on your mobile and hear it while you are in the hospital, in your car, at your home, preparing your food. Everywhere you can hear the patient information leaflet. Also now you are now at the time you can record the station. You can record your station also on your mobile, and you can keep hearing this station 1 time, 2 time, 3 time. Okay, because repetition will fix the information in your mind. Okay, record the station in your mobile and keep hearing this station, and don't miss your knowledge. As I said before, it's very important to revise your guideline, read top guideline, nice guideline, and the dog. And this is to keep on your applied knowledge, because also in the exam we need our applied knowledge. When you had a feedback or a background about the topic, any topic like hypertension, diabetes, you will go in confident to the station. But if you don't know about that, you may be hesitated and shake your confidence in yourself. So please try every day also to read 1 guideline, at least 1 guideline. If you can 2, it will be very good. Okay, and put about only 15 to 20 minutes to each guideline to read the guideline quickly. Okay, this is how to go in the remaining time. Okay, so a study partner is also very important. Every day study with your study partner. At least you can do every day 10 to 14 cases with your study partner. Okay, and repeat the station, repeat, because repetition will fix the information. Not necessary to study a lot of cases, a lot of station. Okay, but you can study only about 120, 110, and you keep repeating this station and practice with your study partner. Your study partner will tell you what are the weak point in your performance. You forget now the folic acid, so in the second time I will not forget the folic acid at all. I will write this in my paper. Okay, and if you make a paper or a handwriting for every station, it will be good. Okay, so keep making a notes or handwriting for the station, because it will learn you what is the point you miss, and you can add this point, so the next time you will not miss this point again. So when I study with a study partner tell me that you didn't interact well when the patient tell you that I wanted to apply a complaint. When the patient he went said, I think this is not competent, doctor. Your reaction here wasn't good. Your reply here wasn't good. So the next time you will do it better. Also, when you lose any information, you miss any information, your study partner will tell you. So your study partner should be very honest with you. and you should feel comfortable with your study partner. If you are not comfortable now with your study partner, you can leave the study partner, no problem at all. Tell him that I am not happy, I am not comfortable. We can search for another one, search for another study partner. Okay, and the one who don't have now study partner, search for study partner in the group, ask in the group, and you will find, inshallah. So gynecology and oncology problem, it is one of our module, very important, and which cover our curriculum, and there are a lot of cases which can be covered in this module. I will not waste my time to enumerate these cases, but I will go directly to the first one. So who wanted to share with us today? Okay, first one, send Dr. Sharda. Okay, Dr. Sharda, you can open your mic, please.
Hello. Good
Hello.
evening, sir.
Good evening, Sharda.
Hello.
Hello. Okay, Dr. Sharda. Okay. All our colleagues, please mute yourself so I can hear Dr. Sharda well. Okay, Dr. Sharda, I will prepare for you, I will arrange for you 2 minutes. Okay?
Okay. Yes.
Okay, start please. Okay, I will adjust 10 minutes.
Okay. Sir. Okay. Hello, I'm Dr. Shraddha, one of the exam candidate, and I'm happy to start my structured discussion.
Okay, Dr. Ashada, you read the instruction and your task outside. So what
Yes.
are the risk factors in this patient?
The risk factors in my patient is that she is HIV positive on some medication, which is not complete whether she is on all the medications or not. She is a single mother. The HIV predisposes her to risk of immunocompromised state. She is a single mother. That means she is vulnerable. She is smoking 20 cigarettes, which and a drug abuser, which again can put her at immunocompromised state. And she is not attending NHS cervical screening. So these are the risk factors.
Okay. And what are the important information you wanted to know about this patient?
Yeah, I would like to know a detailed history from the patient. I would like to know about her symptom, since does she has any pain down below? Is there any discharge, any itching, change in the color of the skin, if there is any lump? Uh, then I would like to know uh, about her menstrual history. Is the periods regular or not? Because because I would like to know about her menopause also. Then I would like to know her any other medical condition for which she is following the GP. Um, and when was her last appointment with her specialist doctor for HIV? I would like to know also about her CD4 count. Is she taking her medicine regularly? Any drug allergies she had? Any surgeries she had? Also, I'd like to know about what does she do for her living? Does she has adequate support at her home? Does she has any sexual partner at present? Is she on any contraception? Is she using condoms? Also, I would like to know her smoking, about alcohol. I would like to know about her BMI, any family history of concern. Uh, I would like to know, especially any cancer. Then I would like to examine her in the presence of a chaperone with her consent. I would like to know her BMI, like to examine, do the per abdominal and per vaginal examination. That's all.
Okay. How you will explain the diagnosis of this patient to her?
In the lay language,
Yes.
I will explain the patient that the tissue test that she had done shows some changes. Uh, these are not cancer at present. This is, as if you look at this diagram, this is normal and this is cancerous, and your tissue test is falling in between. So it has not yet become cancer, but it has a tendency to become cancer. Um, so we need to treat you.
Mhm.
I'll break the bad news. This would be something like a breaking bad news. I would show empathy and support.
Mhm. Anything else?
Yeah, I would like to offer her to the vulval clinic for further treatment.
Okay, this is
Uh,
the last question. How you will manage this patient now?
I would explain the patient that this is VIN and there is a risk of developing sinister changes, which is around 5%. So I'll refer her to the vulval clinic. Uh, in the vulval clinic, she will be seen by a specialist team of doctor consisting of the consultant gynecologist. There will be specialist midwife. The treatment of VIN includes imiquimod cream. This she has to apply. First of all, I will tell her about vulval hygiene. That is, avoid douching, bubble bath, and soap and deodorants. Use soothing moisturizer. Avoid wear cotton clothes, avoid synthetic undergarments and synthetic clothes. The treatment for VIN is imiquimod cream, which she has to apply daily. And then the other treatment is that removal of that is excisional biopsy, that is the surgery. And also there is a laser treatment, but laser treatment will not be suitable in her case. Then I will explain her that she will require regular follow-up. The follow-up will be 3 monthly for the next 2 years, and then I think 6 monthly. I will offer her referral to a counselor because this entire thing might be very traumatic to her. So I'll refer her to the counselor. I'll give her the patient information leaflet and book her appointment for the vulval clinic as well as NHS cervical screening program for the pap smear, for the liquid-based cytology and HPV virus.
Okay.
And also I will tell her that she requires annual screening.
Okay. Regarding her option is, you said, surgery or imiquimod. That's right?
Yes, sir.
What is the pros and the cons of each option?
The surgery, if she undergoes surgery, then the thing is, surgery in that area, it doesn't heal so nicely because there is no adequate rest, and we are moving. Sometimes it may involve plastic surgeon also. Then imiquimod cream is not 100% effective. Some of the patients it may not respond, and then we have to go for other treatment.
Okay. Anything else you wanted to add? You still have 2 minutes. Anything in the management, in the history, you have 2 minutes. You can mention any point, even if it before in the previous question, no problem.
I would like to know why she is not attending NHS cervical screening program.
Okay. Anything else?
I will offer her a colposcopy as well as vulvoscopy in the management, in the investigation.
Okay. Anything else? Okay.
I will put her in touch with the NHS Stop Smoking program if she wishes to quit smoking, and NHS drug stopping program if she volunteers for that.
Good. Anything else? Okay. Thank you, Dr. Sharda. Well done.
Thank you so much, sir. Thank you for giving the opportunity. Thank you so much.
Well done, Dr. Sharda. You did it very well, really. One of the important thing we learned today, what happened now. Dr. Sharda still have 2 minutes, and she finished her talking and finished the discussion with the examiner, but she still have 2 minutes. You will sit silent in this 2 minutes. No, you can talk, and any point you will touch, any point you will mention, you will take your mark regarding this, unless it was unless it was wrong. Okay, so you can still talk even if it was in the previous question or the first question. You can still mention or mention information, mention some point which you miss, and you still take your mark. Once the bell ring, now you will not take any mark about anything you will say. So if you still have time, think think and squeeze your brain. You may touch a point, you may gain 1 mark more, and this 1 mark may make you pass in this exam. Okay, so don't waste your time in the exam. If still you have your time, okay, talk like what happened today, and all the point that you said, all are valuable information. You will gain the marks regarding this point. Okay,
Yes, sir.
so you did it really very well. You touch all the point, or most of the point you touch in the all question. From the first question, what are the risk factor? You mentioned the HIV is a risk factor, which decrease her immunity, make her immunocompromised. Also, single mother, this also will affect her. Smoking also affecting her immunity, and most of the women who smoke can't get rid of the human papilloma virus. Most of the women can take human papilloma virus, which is the main cause of the HIV in this age group. But the woman who smoke can't get rid of this human papilloma virus. She also doesn't follow her in NHS cervical screening program. This also put her as a risk for the VIN. Also, it was drug abuser. So from the psychological habits, or from the personal habits of this patient, she doesn't take care of herself at all. So this was the risk, and you mentioned all of this point. Regarding the information and the history taking, information gathering, you mentioned all of the point, and very well that you go systematic. When you go systematic, you will not miss any information. If you miss, it will be a very little information. So go systematic. Dr. Sharda, from the complaint, start from the complaint. I will ask her more about her complaint. Ask her about this, whether she has any lump, any mass, any pain, any discharge. Very good, very good. Only she misses to ask about some symptoms or sign of malignancy, like loss of weight, loss of appetite, any bowel
Yes.
problem, any water work problem. This is to show the examiner that I put the malignancy in my mind, and I ask about these symptoms and the signs of malignancy. And
Yes.
she go to the gynecological history. Good. Ask about her period, last menstrual period, to see whether this patient is pregnant or no. She may be pregnant, and my management will be different. Okay, because this patient is smoking, drug abuser. I don't know. So, but she missed in the gynecological to ask about the STIs, whether she screened also for any other STIs. Maybe she has any other sexual transmitted infection other than HIV. Whether she has sexual partner, she asked about the sexual partner now. But if she has sexual partner, she has any problem with sexual intercourse, because this is a very important question, may affect the psychological and the mental health of the woman. And most of the women with VIN or lichen sclerosis has a problem with sexual intercourse, like dyspareunia. So if she has a
Yes.
sexual partner, whether she has any problem during sexual intercourse, and how she cope with this, and how her partner cope with that, and whether if she has a sexual partner, she use any contraception or no. Okay, and coming to the cervical smear, why she doesn't attend the NHS cervical screening program? You forget this point, but when you take your time at the end, you manage to mention this very important point. Okay, so now I cover all the gynecological history, from the period, the contraception, sexual activity, STIs, and cervical smear. You can ask about the obstetric also. It may be relevant if she complete her family or no, because if she has any other types of the cancer, it will also affect her management plan. Coming to the drug, the allergy, it is very important point, and you cover this point. Any medical history, any surgery, very good. And regarding the smoking, whether she think to quit smoking and the effect of the smoking, I have to put stress and emphasis on this point. Okay, she smoked 20 cigarettes per day. Whether she think before to quit smoking, and offer her NHS cervical stop smoking service. Whether she drink alcohol, any family history of cancer at all, like that. Very good from Dr. Shada. You mentioned most of the point, and even you didn't forget the examination. Good. This is also as a part of the information gathering. Information gathering, not only history, also examination. It is also part of the information gathering. And if I can review the investigation of this patient and can review the scan, if she had any scan, any other test, I can review that. Also, this will be considered as a part of the information gathering. Coming to the how you explain, Dr. Sharda explained it simply and very good. Okay, and she doesn't forget drawing. Drawing is very important to show the examiner how is good communication with the patient, and it will shorten your time, will save your time. Okay, so explain by the method that you can. Okay, you can explain that this is this is you have a VIN. This is an abnormal cell in the skin of your vulva. The vulva is the lips of the vagina, and this is not cancerous cell. This is not cancerous cell, but it needs follow-up and treatment because it may go to cancerous cell. Okay, I can draw for you. This is the normal, and this is the abnormal, and here is the abnormal in between, and this is a abnormal cell in stages 1 and 2 and 3. 1 near the normal, 3 near the cancerous, and 2 in between. So you are here, and you can show to the patient you are here in the middle. So you have VIN stage 2. This is how to explain for her the VIN. And Dr. Shahada did it very good. Regarding to the management, you mentioned all the point. You forget some point in the start, like NHS stop smoking surface, you forget that, and the cervical screening program, okay, you forget that, but you mention that at the point. The option of this patient, like you said, it has 3 options: surgery or medical treatment and the laser, and you go in details in each one. You have to go in details. You have to mention the cause and the pros of the each one without prompting. As prompting will listen your mind. You will take mark, but you will not take the full mark if you are prompted by the examiner or by the role player. So very good, Dr. Sharda, in this station, really. So let's go to the suggested model of answer.
Thank you, sir, for the excellent feedback and for
Thank
the
you.
encouraging words. Thank you
Thank
so
you.
much.
Thank you, Dr. Sharda. Welcome. What are the risk factors in this patient? The risk factor are the smoking, the HIV, not follow the NHS cervical screening program. She is single mother and was drug abuser. Okay, so what are the information you wanted to know about this patient? I wanted to know, to show the examiner from the start, show the examiner that I go systematic. I will ask about the history, I will examine, I will review her notes. Okay, so if you forget at the end to review the notes or to mention that I wanted to review the notes, you will be safe. So I wanted to know more about her from her history and from my examination and from reviewing her notes. Regarding the history, I will ask about her complaint in details, like this lesion, when she started to feel this lesion, any pain, any itching, any discharge. Ask about the sign and symptom of malignancy, any problem in water work, any problem opening bowel for the metastasis, any loss of weight, loss of appetite, like that. Go to the gynecological history, whether she is sexually active, any pain during sexual intercourse, any problem during sexual intercourse, any bleeding after sexual intercourse, and does it affect her sexual life and how she cope with that. She need any interference, she need any referral or no. Ask her about her period. Okay, ask about if she is sexually active. Ask about the contraception, she use any contraception or no. Cervical smear, very important point to touch. Why she didn't attend the NHS cervical screening program, and I will put stress on that, on the importance of the cervical screening, okay, and offer her referral again and arrange appointment. Coming to the obstetric history, as I said, we can ask her whether she complete her family or no, and whether she was pregnant before or no. Medical history, like diabetes, like thyroid, any surgeries at all, any drug like allergies at all, the drug of the HIV, she used this drug or no, because the HIV, they reduce her immunity. Smoking, and I will put stress on the effect of the smoking on her health and how can worsen her condition. and whether she think to quit smoking or no, and offer the NHS stop smoking service. Alcohol and recreational drug. Social history, very important also to ask her about her living. Yes, what she do for a living, because she is a single mother. So who support her? Who support her? Her baby, if she has children at home, who support her? This will be patient safety. Take care of that point. Okay, so to ask the patient about her job or about her financial support, this will be considered as patient safety. So who support her? Who support her family? And whether her job put her at a risk to catch this infection. She may be uh, uh, any job that put her at risk to catch a sexual transmitted infection. Okay, so I have to ask about that. Ask about her partner. Her partner know that she has HIV or no. This also will be considered patient safety, but not for this patient, for her partner safety. Okay, so this will be considered as a part of the safety. To ask whether the partner know that she is HIV positive or no, and whether the partner tested for the HIV or no, and the contact at home also tested for the HIV or no. This will be all of this. The social history will be considered as a safety point. To ask her about her psychological history, also because this may affect her, this disease may affect the mental health. Okay, you can ask about that. And the family history of cancer, like cancer, vulva, vagina, cervix. Also, this will be a part of the information gathering. Then the examination, don't forget, when I mention the examination, I will mention the chaperone and the consent, even in the structure discussion. Okay, I will examine her vitals, her abdomen for tenderness and the masses, okay, to exclude any masses, may have any cancer in any other sites. The local examination to see the lump, to see the vagina, cervix, can do by manual examination. Okay, how you explain the diagnosis or the histopathology for the patient? Okay, after confirming the patient identity, I will tell her that the test show that you have an abnormal cell in the vulva. The vulva is the lips of your vagina, and this is called VIN. This is not cancerous, but need treatment and follow-up as it may develop to cancers. I have two options of explanation. You can go through any one of them. The first one, this is the second one I have. This is the one explained by Dr. Sharda. This is a normal, here the normal cell, and here is the cancerous cell, and in between the abnormal cell, our VIN. So I will draw for the patient. Here is the normal, here is the abnormal. Oh, sorry, here is the normal, here is the cancerous cell, in between the abnormal. The abnormal will be in three stages: 1, 2, 3. 1 near the normal, 3 near the cancerous, 2 in between. We are here in 2. We are here in 2. This is stage 2 VIN. Another type of explanation, you can explain this for the patient. You can tell her that the vulva is made up of 3 layers. The very top layer called the epidermis, and it is very thin, 1 millimeter in thickness. If the abnormal cells are present in the upper layer of this upper third, sorry, of this layer, it is called VIN1. If it take 2/3, it is called VIN2, and if it involve all the thickness of the layer, it is called VIN3. From your report, you have VIN2. Okay, again, the vulva are made up of 3 layers. The very top layer called the epidermis, and it is 1 millimeter in thickness. If the abnormal cells are present in the upper thirds, called VIN1. If it include 2/3, it is called VIN2. If it include all the thickness of this layer, it is called VIN3. The report shows that you have VIN2. The exact cause of that is unknown. However, it most likely due to infection by virus called the human papilloma virus. In this age group, the most common cause is human papilloma virus, which most of the women can take this virus at certain stage of their life, but most of the women also can get rid of it by their immunity. But some women can't do that. If they have any disease, decrease their immunity, and also smoking may play a role. Okay, this is how to explain for the patient. How you manage this patient? This is the last question. Okay, her management need multidisciplinary team. Don't forget multidisciplinary team, like consultant gynecologist, pathologist, oncologist, sexual health clinic. Don't forget HIV specialist and specialized nurse. I will keep her in touch with the stop smoking service, the colposcopy to rule out cancer cervix, sexual health clinic to screen for other STIs, and also the partner to be screened, and also the contact to be screened for the HIV. Okay, very important point in the patient safety. Okay, cervical screening annually. Why annually? Because any patient with HIV, her cervical screening program changed to annual cervical screening program. I will give her advice about safe sex. Okay, to use condom during sexual intercourse to protect her partner and to protect herself also from catching any sexual transmitted infection. This patient safety. Don't forget safe sex. Then I will explain for her option. Her option either one of three, either surgery or topical cream called imicomode or laser. In the surgery, we'll removal of the affected area. The pros of that, this involve a cure, biopsy to be examined for any cancerous lesion. As underlying cancer, this patient may have underlying cancer about 20 in 100. The causes of the infection like pain, infection, scarring, distortion, which need cosmetic surgery. Regarding to the cream, imicomode, explain for the patient this cream use her immune system to attack the area of the VIN. And this means that it uses her body defense mechanism to kill the precancerous cells in this area. The bruise, no surgery at all, can be applied by the patient at home and can be used in the recurrence. But regarding to the cones, this cream makes severe burning sensation, which make the patient to stop this cream. The laser, the failure rate about 40%, high failure rate, and only can be applied to the non-hair bearing area. This patient should be counseled that if the VIN even treated, there is also still risk about 5% to have cancerous later on. She should be advised about to keep eye about her vulva and to be alert about any changes and seek medical advice if she has any changes in her vulva. Any question?
Hello.
Hello, Dr. Ajit.
Hello.
Hello,
Dr.
sir.
Ali.
Yes, Dr. Hussam. Okay, can
بس
we
I
hear
want...
Dr. Ajit first?
Okay,
Dr. Hussam.
because ماشي okay.
Okay. Dr. Ajit, okay, I'm with you.
Yeah, sir, I want to ask that as the patient is HIV positive and already immunocompromised, so will we offer her imiquimod in
Yes,
this particular case?
This is contraindication to imicomode.
No, as it acts by using your body's immune system, so that's why I was confused, like
I
whether that
don't
will be
know.
effective.
I don't know whether this is a contraindication or no, but I don't think that.
Okay, sir, then I'll see.
Okay.
It may be used more for genital warts, human papilloma virus, but it's mentioned it's used in case VIP with 5% fluorouracil and something new. It's called photodynamics therapy also. But I don't know if this يعني evidence based or not.
This is for human papilloma or for VIN?
VIN يعني it's mentioned in some textbooks that imiquimod 5% which called under the name of Adara in the market, and also 5% fluorouracil cream and something new is under research. It's called photodynamics therapy. All of this under research can be used in VIN.
Yes,
And
the one The one I
And
read about the imiquimod, this is from the patient information leaflet. They mention the imiquimod cream. All the patient information leaflet that I read UK patient information leaflet all mention imiquimod cream.
And regarding the surgical management, it varies from just focal lesion, local excision to wide excision, or we do simple valvectomy if there is Paget's disease, so that we should ask the patient if there's breast lump or history of breast cancer, because may be related to this VIN. And another surgical skin valvectomy if the patient is sexually active and has a wide lesion, we can use the skinning valvectomy.
Yes.
I want to mention that in this slide in front of us there is some mistake. It's written that if the abnormal cells are present in the upper third of this layer called VIN, it's in the deepest third. The lesion starts from the deep above, not from the surface below. Do you understood me? يعني VIN it occupies the deepest third of the layer, not the upper third. Then the
The
CIN
biggest layer, the upper third of the layer. Yes, and you mentioned that. You mean that
the
will be
deepest
the
third.
deepest layer, and this
Yes,
is
yes, that's wrong.
yes to say. Okay,
Is the
okay,
deepest third from below above.
okay.
That's it. But
Dr.
I want
Ali,
to
can
ask
I
Dr.
have a quick one?
Dr. Ali, I want to ask you in this patient when he يعني mentioned that the patient is HIV positive, should I go in depth about HIV and talk if still much of time about, because it's the management of VIN is closely related to the management of HIV. I think that, for example, cervical slimming should be annually, not every 5 years or 3 years, according to the age of the patient. If she is not controlled, this may يعني affect the match and expose her to risk of infection. What's your opinion?
My opinion is to touch the point related to the HIV to our task today. So you will not go in details in the HIV and the management of the HIV. No, what is the relation between the HIV and our task today? As you said, her cervical screening program should be changed to be annual instead of 3 years or 5 years according to her age. So it should be annual. Okay, ask her about to screen about any other sexual transmitted infection. Refer her to the HIV specialist. Screen the partner, her contact, whether she informed the partner or no, what is her job, like that. Okay, because sometimes you have to notify the job. If this patient, for example, is a nurse, so you have to notify, or a medical, any job in the medical field, so you have to notify. Some jobs you don't have to notify, like if you work in the food or in secretary like that, you don't need to notify. But if this patient may spread the infection to other people, so you have to notify. This is the relevant question you have to ask about the HIV, which keep you in touch with our station today.
Okay, thank you.
Welcome, Dr. Hassam. Thank you for your good knowledge and good information.
Dr. Ali, this is Dr. Anila. Can I take a quick query?
Yes, yes, Dr. Anila. Yes,
Yeah,
sure.
thank you so much for being such a kind mentor. And I just wanted to mention that there was a scientific impact paper on cervical cancer. So I had taken my notes from there, but this is regarding the invasion of human papilloma virus in the cervical epithelium. I don't know if vulval epithelium is different, what Dr. Hossam was saying. What he meant to say was that in that scientific impact paper, it was written that virus invades through micro abrasions in the skin. Then it resides in the cuboidal cells, which are the cells very close to the basement membrane, because we all know that the epithelium has a superficial flat layer, and then the middle polygonal layer, and then the lower cuboidal layer that rests on the basement membrane. So according to that scientific impact paper, when HPV infects the cervix, cervical epithelium, the cells invade through microabrasions in skin, and then they reside in the cuboidal cells, and then they start creating abnormal cells which grow up, and then they get detected. And from that scientific impact paper, me and Dr. Hussam got this impression that when we are talking about the cervical epithelium, so this is the impression we got. Maybe we are wrong. That when upper 1/3 of epithelium is infected, then it is called CIN1. If 2/3 CIN2, and if whole of epithelium CIN3, maybe we understood it wrong. So if at a later time, if you could go back to that, like maybe vulval epithelium is different, because that can make or break our impression in the viva. Okay, so please get back to us on that. Thank you so much.
Okay, thank you, Dr. Alina. But I want to tell you that this explanation of the VIN, I took it copy paste. This is not from my mind at all. I take it copy paste from patient information leaflet. I will send the patient information leaflet for you. Then I will take it from the UK trusted patient information leaflet. And I take it copy paste. This is this one explanation of the VIN. If this not go with you, not fit with you, you can explain the other one. It is simple, as Dr. Sharda said.
Thank you.
Dr. Ali,
Welcome.
Dr. Ali, can I also
Yes.
speak? Yeah,
Dr.
actually,
Sharda, yes, sure.
the previous two candidates, what they spoke, I also know the same thing. It grows from downward to above,
Close from.
down basement to above, lower 1/3, then lower 2/3, and the entire.
Okay, okay.
Thank you.
Welcome.
Hello. Yes, sir. Dr.
Hello.
Reena here. Sir, I think this starts from the basal layer and then it proceeds superficially. It starts from the basal layer, they say, and
Yes,
then progresses forward. And when it involves the entire thickness, then it is 3. And from the basal layer to basal 1/3 is called as VIN1 and 2/3 is
yes, yes.
2. And then when
Well,
it enters
yes,
from basal to superficial, then it becomes VIN3.
yes, yes. I am with you. Yes,
Yes, sir. Thank you, sir.
thank you. Any other comment? Any other question? Okay. Let's go to the second this station. Who wanted to share with us?
Can I do, sir?
Yes, Dr. Antasar, you did it. I think you did some station in before. Okay, if no
Okay,
one doesn't want,
only
okay, you
one.
can share. You
If
can.
anyone,
Yes,
okay, I can delay my.
yes. I want anyone new to wanted to share with us.
Can I do so?
Yes, Dr. Odi.
Yes, yes.
Okay, welcome. Okay, I have just 2 minutes for you.
Wait, sir. Wait, sir. I didn't get.
What?
1 second. 1 second. I lost my
1 second.
screen.
Yes, okay, no problem. Take your time.
Uh, yeah, I lost my screen. Yes, I got it.
Okay, you have 2 minutes from now. Start. Sorry. Okay, I will adjust the 10 minutes. Start.
Hello.
Hello.
Hello, I'm Dr. Adi, one of the doctors in the clinic today. How may I call you?
Jan.
May I confirm your age?
Your voice not clear, Dr. Audi.
Yes, yes, Dr. Ali. Can you give me 1 minute so that I can fix and then
Yes,
get back to
yes.
you?
Take your time. Yes. Okay, no problem.
1 second.
Okay, no problem.
Hello, is it clear?
Yes, now clear.
Yes, sorry.
No, no, at all. Welcome.
Yes. Hello, I'm Dr. Adi, one of the doctors in the clinic today. How may I call you?
Call me Jan.
Yeah. May I confirm your age?
I have 60 years.
Jane, I understand that you have been referred by your GP because of your concern with your scan. Is that so?
Yes.
Is there any other concern and expectation from today's consultation?
No, I wanted to know what will happen next, doctor.
Yes. Before addressing your concern, will that be okay if I ask a few more questions to know more about it?
Okay.
Yeah. Could you please tell me about your condition?
Yes, I have bloating in my tummy since since a few months, and I lost my appetite. Sometimes I have a loose motion. All of this I keep down to my problem before. I have irritable bowel syndrome, and I take some medication for that for many years. But my medication not helpful at all for my new symptoms. So I went to my GP, and my GP request for me some tests and advised me to come to the hospital today.
I'm so sorry that you are going through a lot. And do you notice any swelling on your tummy?
No.
And how? And do you? How is your? Do you notice any loss of weight?
Yes, my daughter noticed that I lost weight in the last few months.
And how about your waterworks?
No problem.
Are you taking any medications right now?
No, some drug for only the pain, like painkiller and antispasmodic.
Are you allergic to anything?
No, at all.
How about your periods?
I'm 60 years. My period stopped since 5 years.
Okay. Are you up to date with your smears?
Yes.
And are you using any hormone replacement therapy?
No.
And have you ever been pregnant before?
Yes, I have two daughters. One is 25 years old and one is 30.
And do you know your blood group?
O positive.
Do you have any idea about your weight height ratio?
Yes, 28, I think.
And in case it is needed, do you have any reservations for blood transfusion?
No, at all.
Are you visiting GP for any other condition other than this?
No, only my irritable bowel.
And do you have any other operations on your tummy or down below?
No.
Is there any family history is concerned to be shared with me?
Yes, really. My grandmother died with ovarian cancer at the age of 60, and also my sister and my niece has a breast cancer at the age of 40, and they did surgery for that.
I'm so sorry to hear that. And uh, are you well
Thank you.
supported at home?
Yes, my partner is very supportive.
And if you don't mind, do you smoke?
No,
Do you take any alcohol?
no,
Any recreational drugs?
no,
Have you ever felt down, depressed, or loss of interest in the surroundings for the past 4 weeks?
no at all.
And thank you for sharing all the information. Is there anything
Thank you.
else you want to share with me?
No, no, doctor. My GP told me, called me since 2 days, and told me about the result of the scan and the result of my test. And he told me already that I may have a cancer. Am I have a cancer?
Yes, coming to your concern, Jane, I have confirmed your name and NHS number of your scan report, and what the scan report is showing. Are you alone today, Jane?
Yes, I came alone today.
Okay. Do you want to be someone with you?
Why?
I have some concern with your scan report.
Hmm. Okay, doctor,
Shall
you can
I?
tell me. I
Yes.
can cope with that.
Yes, because the scan report shows the cyst in your ovary on the which usually it's for 10 centimeters. That means to say it's a bigger cyst is there inside your tummy, and and it is showing some concern in that. Usually, and also you have been done with some of the investigations with the GP. I have gone through the notes, and that is called a protein in your blood. And when we assess the risk of a patient by using this method of RMI index, and which shows a little bit. It's a little bit on the higher side. Because of that, we may need to refer you to the multidisciplinary team of doctors. That means to say the specialist doctors to assess what best can be done for you. Am I clear so far?
Yes, yeah, please. So, you will offer me surgery?
Yes, because of the concern with the protein, and as well as the scan report shows that there is a cyst inside your womb, and the risk index which appears to be in the higher side. So you may need another imaging also, and we will discuss. We may recommend you for the discussion with the multidisciplinary team of doctors, and usually you may be advised for the surgery by removal of the womb, and as well as both ovaries and the tubes, and sometimes the fatty layer which is covering over the organs, and sometimes we may need to take some of the fluid inside your tummy, and some of the areas where there are suspicious also, to make sure that there is no other abnormal cells inside your womb, in your tummy. Am I sure? Am I clear?
Yes, you are clear, doctor. So, what is the percentage that I may have a cancer?
Usually, so most of the one in the general population, you have a 1.7%. That means to say like 1 to 2 in 100 they may have a cancer. And that also that depends upon the family history also. And in your case, there are some family history concern, so the risk is slightly on the higher side. Maybe it is 10 in 100, and that is the reason you may be offered with the surgery of this nature. And sometimes if depending upon because after the surgery the tissue will be sent for the microscopic examination, and depending upon the spread of the cancer, you may require some of the more medications like a chemotherapy, what we call, after the surgery. Am I clear so far?
Yes, yes, doctor, you are clear. Doctor, I am a nurse, and I Google about that cyst and about the possibility of cancer, and I read that there are a lot of tumor markers that can make. Any other tumor marker I can do
Yeah.
to be sure whether I have cancer or no?
Yes, sure, Jane. Because after the 60 years, most of the women with the ovarian cyst, we go with the CA-125. That is the protein which we estimate, and there are also other proteins like LDH, and other proteins also. Cancer antigen also we can look after into the thing in your blood. And but most of the times in postmenopausal woman, we assess by the ultrasound features, which your ultrasound features shows there is the cyst is having multiple cystic areas. So that is the reason we have assessed the risk assessment with this protein. Am I clear?
Yes, you are clear. Time's finished, but I will complete with you for 2 minutes more. Okay, doctor. Now, I am afraid for my daughter. I have two daughters. So are they at risk to have this problem?
Yes, depending upon because of your family risk of the cancer in your family, because there are more than 2% are in having the cancer, there is a increased risk to about 15%. So your doctors may be offered to the counseling with the genetic counselor, who can advise them for the screening for the gene, BRCA gene, which if it is present, they may be advised for the prophylactic removal of their ovaries and the tubes after their completion of the family. And and it may be advised for them for a genetic counseling, and I would like to refer them for genetic counselors. And I will also give you the information leaflet, which you can go through them so that you can have an idea about what we have discussed. And I can also put you in support with the support groups who can give you a lot of support in this stage. Will that be okay for you?
Yes,
And
very
I will
good,
write
doctor.
back. Yeah, I'll write back
Okay,
to the GP the same
one
thing what
question
we have
more.
discussed.
One question more, doctor, if you please, if you have time, please. I'm afraid, should I have removed my breast also? Because my sister also have breast cancer. So should I have to remove my breast?
You will be put under the regular annual screening for the breast, because there is not like a prophylactic removal of the breast, because unless you are having the gene, and also you will be with the regular screening the gene for your breast with the mammography, so that
Okay,
if at all anything is there, so you may be advised for that.
okay.
Yeah, I will put
Thank
you
you.
an appointment with my consultant also, so that you can discuss more about that.
Thank you.
Thank you.
Thank you, Dr. Audi. Well done. Really, this is one of the difficult scenario, one of the difficult station, and Dr. Audi did it in a good way. She mentioned most of the point in this regarding the history taking and the communication, patient safety. I think you touch most of the point, except a small point. You will comment on that. First, your communication. Regarding the communication, your communication will be assisted when from the first moment you enter to the cubicle, you enter to the station, when you meet the role player, how you introduce yourself and how you confirm, checking the identity of the patient. So better to ask about the name in one question and the age in one question. This may waste your time. I think it's better to ask about the name and the age in one question, because it will serve your time. But it is for you. If you wanted to ask about the name in one question and the age in another question, no problem at all. After that, you're checking the purpose of the meeting. Good that you're checking the purpose of the meeting, why she is here today. You can ask, how can I help you? I understand that you are here today after the GP requests some test for you, and you are here to know the result of the test. Very important point I wanted to stress, to ask the patient about the background. This is very important point. If the patient came today to know the result, to explain the result for her, to know the result of the scan, the result of the test, you have to check the background of the patient, whether this patient know anything about the result, or know anything about the result of the test, the result of the scan, and this to know from where you will start, the starting point. This the patient doesn't know at anything at all, so you will do breaking bad news, because it will be the first time for the patient to hear from you that she may have a cancer, or she have a cancer, like that. So this will be different at all. Or already the patient know about the result. The patient know that she has cancer. The patient know that she has a cyst and high suspicious of cancer. So it will not be a breaking bad news, because the patient already know about the news. So how you will break bad news now? So asking the background, or checking about the background. Do you know anything about the result? Any idea about the result? This is very important question, and this will be a good information gathering, good point on the information gathering, to know the background of the patient. The patient may say, yes, yeah, the GP told me already. He called me yesterday or since 2 days and tell me that I have cyst and I have a high suspicious of cancer. Okay, so now the patient know that she has a cyst and highly suggested cancer, or highly suspicious of cancer. So it will not be at all breaking bad news at all. Okay, so checking the background from the start will be considered as information gathering, and it will be very important to ask. After that, you put your agenda. Very good. When you put your agenda and ask about the complaint, you analyze the complaint. Good. Ask about the symptom of the mass, of the ovarian cyst, and also you ask about the symptom of malignancy, like loss of weight, loss of appetite, like that. Very good. The gynecological history, you ask about the cervical screening program, and this is a safety point. Very good. And you didn't ask about the obstetric history. Here the obstetric only to know whether she has any daughter or no, because any daughter of her may be at a risk to have also this ovarian cancer or breast cancer because of the cancer genes. So do you have any children? Do you have any daughter at home, like that? Have you ever been pregnant before? Any question to know whether she has a daughter or no. When you ask a relevant question, it will waste your time and show that the examiner that you will not concentrate with the patient. What are requested from you? If you ask about the blood group in this patient, no need for the blood group, I think, for this patient. Also body mass index, I think it will waste your time. Blood transfusion, you can keep the blood transfusion when you explain the surgery and the complications, like that. Okay. Also smoking, alcohol, all of this may be waste your time. It will, I think it may lose 1 or 2 minutes asking about that, and you will not take any mark regarding this point. So try to ask relevant question regarding to your scenario. Any medical at all, any medical history, good point. Okay, any surgeries at all, because this may have a surgery after that, and you know the difficulty of the surgery if she opened her abdomen before. Very good question. The most important question in the information gathering, it is the family history. Family history was very good question from you, Dr. Aoud, when you ask about any history of cancer. any history of sinister cell at all, and she told you that her grandmother has ovarian and his sister has also a breast cancer. So from this patient, you may know this is a cancer gene run in family like the BRCA1, BRCA2, and hereditary non-polyposis cancer colon, any of the cancer gene. So this is regarding the information gathering. Coming to explanation, this is not breaking bad news. As the patient already know about the result of the scan, so don't break bad news for this patient. You explain the result very good about the CA125 protein secreted, and it increased in about half of the patient with cancer ovary, and also may increase in another not sinister cell like that. And regarding the system, explain it in a good way. The management plan. Coming to the management plan of this patient, I think this patient, when you calculate the risk of malignant index, it will be about 162. So her risk of malignant index will be less than 200. So this patient will be offered bilateral salpingio-oophorectomy. Bilateral salpingio oophorectomy, laparoscopic bilateral salpingio-oophorectomy. And as you said, the tissue will be sent for the histopathology to check for any sinister cells after that. If she has any sinister cell, her management plan will be changed at all cancer center, multidisciplinary team, do staging laparotomy like that. We will see in our suggested model of answer. Regarding to the question of the patient about her tumor marker, when she asks you about the tumor marker, there is no evidence based about any other tumor marker. We can do other tumor marker if the patient has complex cyst less than, and if the patient is less than 40, to exclude the germ cell tumor like beta HCG, alpha-fetoprotein, and lactate dehydrogenase. Regarding to the question about her daughter, you did it very good. You did it very well. There may be a cancer gene run in her family, and her daughter also at a risk. So I will refer you to the your daughter need to be referred to the genetic specialist, may offer her screening, and also she may offer risk reducing surgery. This is the point I wanted to comment, and a good well done, Dr. Audi, for this task really. So let's go to the suggested model of answer before I will hear your question. Okay. This patient, you go from the start, this patient has a cyst, and this cyst may be suspicious of cancer. Please mute yourself. Dr. Isma, please mute yourself. Okay. So better no smile when you enter the cubicle, no nice to meet you, okay, because this you will also explain something bad for her, and this patient has some problem, okay, so better not to say nice to meet you, or and don't be funny, okay, be natural when you enter the cubicle, be serious. Hello, I am Dr. Ali, one of the senior doctor in the clinic. May I confirm your name and age, please? She will say Jan, and I am 60 years. Okay. Understand that you are here today to know the result of the test is requested by your GP. Am I right? Yes. Checking the background, very important. Do you know anything about the result? She will say yes. The GP called me yesterday and told me about the cyst and the possibility of cancer. Okay, so now you know the starting point, your starting point, from where you will start. Okay, show sympathy. Don't forget to show sympathy when the patient tell you anything bad. I'm so sorry for that. I'm sorry to hear that. Okay, so the patient, it can't go at all, and you will not pass in the communication when the patient tell you something bad like that, and you say okay, and you go to the next. What is okay? Not okay at all. It is not okay. The patient tell you that there is a possibility of cancer. The GP told her that there is a possibility of cancer, and you didn't show any sympathy for the patient. It will be very bad in the communication. So, as I said, I used to say the one who will pass in this exam who can act, even if your applied knowledge not proper applied knowledge, not strong applied knowledge, but you can act. You can show the examiners that you are a good actor with the role player. You can still pass in this exam. So your facial expression, the exam will be very important. Okay, non-verbal communication, very important. I am so sorry for that. Jan, before we explain the result of the test, can I ask you some question to know more about you? Is it okay for you? She will say yes, okay. Then go to your template. Could you tell me more about your symptom? Yes, I have some bloating, loss of appetite, and diarrhea. I put down all of this for my irritable bowel syndrome which I had since years. And my GP requests some test for me and scan and sent me for the hospital today. Mm, mm. Any problem in water work? Any problem in opening the bowel? To check about this. Any loss of weight? Check about the symptom and sign of malignancy. Have you offered any treatment for that? She said no. Have you ever been pregnant before? As I said here, to check whether she has any daughter. Okay, yes, I have two daughter, one at 25 and one 30 years. And how they are now? Good, they are good. They are fine. Okay. And what about your cervical mean? Up to date is normal? Yes. Are you following your GP for any medical problem? She will say, yes, I have some irritable bowel and I take some medicine for that. Any surgeries at all? Okay, to exclude that she has any surgery, to check the possibility of difficulty in other surgery will offer for her. Any allergies at all, any drug, any smoking, and social history. What do you do for a living? She will say, I am a retired nurse, so I have some background of the cancer. Are you someone right now? Yes, my partner. You can ask here the psychological history because this problem may affect her mental health. Family history is very important here, as I said. Her grandmother has died with ovarian cancer, and her sister and niece have both has breast cancer under the age of 40. You here also have to show some sympathy with the patient. So I'm so sorry for that. And how they are now? She went said fine after doing surgery. Okay. And you want to add anything? Thank you for sharing this information with me today. You can examine the patient. I want to examine you in the presence of chaperone if you don't mind for pulse, blood pressure, tummy to assess for any pain and any mess. Coming to the result, okay, the GP has requested for you some blood test for a specific protein called the CA125, which increase in about half of the patient have ovarian cancer. And this is about 18. And this can be found in a healthy postmenopausal woman. The scan shows that you have a cyst in your ovary, and this cyst is a large in size, about 10 centimeter, and has some features which increase suspicious of cancer. And you can draw this is your ovary, and this is the cyst, and this is cyst 10 cm, and show some solid area and some cyst like that. So in this case, we calculate a score called risk of malignant index, which can give us an idea about the possibility of cancer. And in your case, it is about 162. So your care will be under a group which include 1 to 3, as we know. And you will be offered you may be offered laparoscopic bilateral salpingophractomy, where we will remove the both tubes and ovary through a keyhole surgery, where there will be a telescope containing camera introduced through your tummy through 2 to 3 cuts. Okay, then the tissue removed will be sent for histopathology to be examined. And if cancer confirmed, you will be referred to the cancer center, where they will be offered another surgery to remove the womb and the remaining tissue, if any tissue left, and some of the lymph node. I'll give you now some patient information leaflet to read and the consent to sign. You will offer consent to sign before the surgery because there are some complications may happen during the surgery, like 1, 2, 3, damage in the bowel, damage in the bladder. Sorry, you may have blood transfusion. Do you have any concern regarding blood transfusion? You can here mention the blood transfusion. Also, your daughter may need to be referred to the genetist. This is if she doesn't ask you at all about her daughter, you have to mention the daughter without prompting. Your daughter need to be referred to the genetist to offer screening for some cancer gene like BRCA1, BRCA2, and hereditary non-polyposis cancer colon, which may run in family. I will arrange another appointment with my consultant to see what can be offered for you, and I will give you some patient information leaflet and the contact number. After finish if you have time still, the role player may ask you some question like that. or even if it's a structured discussion, the examiner may ask you this question. Okay, so how much is my risk to have ovarian cancer? It will be according her risk of malignant index according to the Green Top guideline. If her risk is less than 25, her risk to ovarian cancer is 30%. If her risk of malignant index is 25 to 250, it will be about 20%. And this is our patient today because her risk is between 25 to 250. So her risk to ovarian cancer is 20. If her risk is more than 250, so her risk of the ovarian cancer will be 75. Okay. Okay. I read about some tests can be offered for ovarian cancer. Any other tumor marker I can do? This is in the a woman under the age of 40. In case you have complex cyst, we can do some tests for the tumor marker to exclude something called Germ cell tumor. But according to your age, it's not necessary now. Okay, and you can mention, okay, and remember this because in the section discussion they like this tumor marker very much, and they ask specifically about each one. Beta SG for each tumor, lactate dehydrogenase for each tumor, alpha-fetoprotein for each one. Okay, so you can mention that and study it by your heart because in the section discussion sure you will be asked about that. Okay, doctor, where you will refer me, or what is the time scale I will have my operation? According to the national guideline, the patient with ovarian cancer should be seen within 2 weeks of the referral and should have their treatment within 31 days from the decision to treat. Okay, if from the result of the histopathology I have cancer, what kind of operation will I need? Okay, so now if you confirm that you have a cancer, you will refer again to the multidisciplinary team, and the treatment will be in the cancer center. You will offer laparotomy and the full staging. We will do midline laparotomy. This all will be in a lay language. We'll remove all the womb and do bilateral salpingectomy if not done before. Do a mental biopsies from the surrounding, and cytology. This is, I mentioned all of this because the section discussion you will ask it about that. Okay, we can do also a dissection of the lymph node. And after that you may need also adjuvant chemotherapy. Okay, so is there any risk to my daughter? Any investigation to be offered for them? Yes, your daughter need to be referred to specialist genetics who offer you them a testing for the cancer genes which may run in family like BRCA1, BRCA2, and hereditary non-polyposis cancer colon. Okay, this is how to calculate the risk of the malignant index. Okay, as all of us know that the risk of malignant index will be calculated by multiplying the menopausal status and the ultrasound score and the level of the CA125. Okay, if the patient is postmenopausal according to the menopausal status, it will be 3. Premenopausal, it will be 1. The ultrasound score, there is 5 features. If there is multinuclear cyst, solid area metastasis, ascites bilateral. Okay, each one of this will take 1. So if it is 0 at all, so no one of these, so the ultrasound score will be 0. Okay, if take 1, so the ultrasound score will be 1. If it take 2 to 5, so the ultrasound score will be 3. Okay, and after that we will calculate the risk of the malignant index. Okay, this is the percentage of the possibility of ovarian cancer according to the risk of the malignant index. If the risk of the malignant index is less than 25, it will be 3. If it's between 25 to 250, it will be 20. If it's more than 250, it will be 75. And this is a flow chart, very, very important one in the part 2 and part 3 to study this by your heart. The flow chart management of the postmenopausal ovarian cyst. Okay, we will do the CA125 for any postmenopausal ovarian cyst, but should be more than 1 cm. And we'll calculate the risk of the malignant index. If it's more than 200 from the start, I will do CT and refer. CT and the referral. Okay, if it's less than 200, so I have 2 options. If the cyst is asymptomatic, simple, unilateral, uninuclear, A to S to U, A to S to U, A asymptomatic, to S simple, small, to 2U, unilateral, unilocular. So I will go with the conservative. I will review here again after 4 weeks. I will do the same transvaginal and CA125 to calculate the risk of the malignant index. If it resolve, discharge. If it's persistent till 1 year, I can discharge the patient if there is no change at all till 1 year. If any change, I can consider intervention. If any of this feature not apply, like if the patient has symptoms, if this is not simple cyst, if it is multinuclear bilateral, like our case today, so I will do bilateral salpingo-oophorectomy, and this will be laparoscopic. Any question?
Yes,
No, Dr.
doctor.
Ali.
Yeah, Doctor,
Muhammad? Dr. Ali?
Okay. Dr. Antisar?
Yes, please, sir. I wanted to ask if there is the RMI become in this case to be more than 200. I will not explain to her the plan of management. I will tell her I will do CT, then I will refer you to the cancer.
Yes.
I will not explain all that.
You can explain that you may be offered the surgery like 1, 2, 3, as Dr. Audi said. Dr. Audi said the management, if the score more than 200, it was very good from here, but the score was less than 200. But as Dr. Audi said, I will refer you to the cancer center or the oncology center. Your care will be under a group of doctor like 1, 2, 3, 4. You may be offered the surgery. This surgery may include removal of the womb, removal of the both tubes, removal of both ovaries, and also take biopsies from the surrounding, take of the some of the lymph node, like that, and will be sent for the histopathology to be tested. Yes.
Okay, sir. I mean, then we, in this case, because the RMI was less than 200, so according to the guideline, we told her they were going to remove it, both ovaries. But actually, in the guideline, it didn't specify to be with laparoscopy or laparotomy. Isn't be safer for that patient in order to tell her to counsel her for a laparotomy, and then to take, for example, during surgery, the frozen section, because there is a possibility to be cancer or not. So if it is not cancer by the frozen section, I proceed for bilateral salpingo-oophorectomy. If it is proved to be cancer, I prove for staging laparotomy. Of course,
yes.
this is after MDT surveillance, or MDT consultation. Not
Yes.
mine. I did not look at ST5.
I know. Okay, you can mention to the patient that I will take consent. When you take the consent, even you want when you take consent for laparoscope, also you will take a consent for laparoscopy. The patient to go for laparoscope, you will tell her that we have a possibility to open your tummy laparotomy. If there is any suspicious of any other tumor, any other suspicious of the cancer, I may do another surgery. According to the frozen section, not all the center or not all the trusts make frozen section. Okay, I have read that some center do frozen section and some center doesn't do this frozen section. So according to our guideline, we have now bilateral salpingo-oophorectomy. And after that, we will send the tissue for histopathology. If we confirm that, you will have another surgery on another set. So I will not offer her now removal of the womb in the same surgery. No, I will do a bilateral salpingo-oophorectomy, and in another set, I will refer her to the cancer center, and after the cancer center will decide her.
But I am allowed to her about that and let her choose. I'm allowed in the exam to tell her that and let her to choose.
About laparoscopic and laparotomy?
Yeah.
Yes, you can explain. It will be very good from you. Yes, to explain for her. We have good, and explain
the examiner will not be. You have an objection over me to talk about all that.
No, at all. No, at all.
Job.
No, you may. No, it is a decision of the patient to have laparoscope or laparotomy. Okay, but to tell her the pros and the cons of each one. After laparoscope, you will have a rapid recovery, early return to daily activity, shorter hospital stay, like that. But there are some complications like failed laparoscope. You may have injury in the bowel, injury in the bladder, like that. In the laparotomy, you will have 1, 2, 3, 4, the pros and the cons of each one, and the patient has to choose.
Okay, and even I'm sorry to take a long time, sir. Even I
No,
can
no, no, no
tell
problem.
that I could, the cyst could be ruptured. One of the cones of the laparoscopy could be ruptured during removal, and if it is proved to be cancer, this will elevate.
Good. If you mention that point, it will be very good. Okay, if there is a spillage during, if there is a rupture during, okay, we will take biopsies from the surrounding. We may need to open your tummy like that. Okay.
Yeah, because of the age and of the susceptibility, and I want to direct the patient toward the pros of the laparotomy. Here, it is not an
Don't
ordinary
direct the
cyst.
patient. Don't direct the
Excuse
patient.
me.
Don't put in
Dr.
his
Excuse
Ali,
mind.
me,
I want to
Dr.
ask
Ali,
one.
the
Yeah.
2016 new guideline on postnatal ovarian cyst clearly mentions like laparoscopy, bilateral salpingography is a suitable treatment to be offered when the RMA is less
Yes.
than 200. It
Yes.
doesn't talk
Yes.
about laparotomy.
Yes. Okay.
Yes, I
Yes.
know. No, I'm sorry. I'm not, because there is a possibility, of course, after that to be pregnant. To be malignant. To be in malignancy, because CA125 is even maybe normal in a patient with cancer. Okay, I'm sorry, sir. I mean, not to argue, because I'm just want to ask if I could tell all that to the patient.
If you mention, I think it will not lessen your mark, and it will not be bad. You can mention that laparoscopy or laparotomy and give her the pros and the cons of each one, and the patient
Yes.
has to choose, but don't direct the patient.
Okay, sir. Okay, thank you. Thank you.
Welcome.
Dr. Ali, one question.
Yes, sure.
Yeah, I want to ask that when we are explaining the patient regarding her ultrasound, or in this case, she was knowing about possibility of cancer, the risk of malignancy index telling her about the score, your risk is less than you will be. So will she be able to understand as a patient in a layman that what is risk
Yes,
of malignancy index?
yes, I know that it would be it's difficult to any patient to understand, but because this patient is a nurse and she said to me, I has read about and I have knowledge about, I may explain to her the score. But if this patient in other job other than nurse, it is a housewife, no knowledge at all, so I may skip this, and I tell her that from your scan and from your test, your risk may be high, your risk may be low, like that, and skip the risk of the malignant index. But because of she is a nurse, because she is a nurse and
Okay,
she
we can
read
amend this thing.
you can do that.
Okay, thank you very much. Thank you very much.
Welcome.
Dr. Ali?
Yes.
Yeah, at one point, the role player was asking, am I having the cancer doctor, before I explain. So in that case, should I assume that he knows that he's had cancer, she knows that she's having cancer, or should I go with the breaking bad news? That was confusing for me.
Yes, when I asked you from the start, I asked you this because you didn't check my background. If you are checking my background from the start, I will not ask you that one, because I will tell you that I read that I have a high possibility of 1, 2, 3. But so you didn't ask me, so I wanted to stop you and at this point to explain for me. If the patient says that, you can explain for her, it is not likely, or I will come in a moment to explain that for you. I wanted to tell you what will happen next. Okay, you can skip from that point till you will explain for her the result of the scan and the result of the test, and calculate your risk of the malignant index, and give her in a smooth way. Don't tell her from the start, yes, you have a cancer, or don't ignore it at all, or say no, you don't have a cancer at all. No, keep in between. Okay, you can escape from this point. I will come in a moment to explain that for you. I will tell you that what can be happen for you. We have a lot of things done before. We can tell you what this is a cancer or no, like that.
Dr. Ali, one question.
Okay, thank you.
Okay, welcome.
Yeah, regarding the possibility of having a cancer, it will remain always a possible, no? Because it will be a histopathology
Yes.
diagnosis. So when the patient is asking, am I having a cancer? So I feel that means we should always be, the possibility of having a cancer is low, high, or something like that, because it will be
Yeah.
after your surgery and the test which will show whether it is a cancer or not. At this particular moment of time, the possibility seems to be low. Is that the correct way of telling?
Yes. Also, as we said, according to the guideline, we have some knowledge about the guideline, and here your knowledge will be appear in the exam. If you said for here, according to your score, your risk is about like that, it will show the examiner how you have applied knowledge about this, the applied knowledge or strong knowledge about that cancer. If you don't know what is the percentage, you can skip. It isn't in my mind. And if she asks you specifically about the percentage, like I did today with Dr. Aoudi, when I asked her, hey, what is my percentage to have ovarian cancer? And you don't know, you can skip, and you can say it is not in my mind now. I will review the literature and I check with my consultant and I give you feedback like that. Don't say anything wrong in the exam. If you don't sure about your information, don't tell it, because it could be considered patient safety. Saying I don't know better than saying something wrong. So I don't. It is not in my mind now. I will check and I will tell you later. And I remember in my exam I said that. I said for one question or two question in my stations, the role player asking me something. I think about side effect of drug, and I say whether it suitable in my pregnancy or no. And I said I don't know. I don't know. I will check, and I check with my consultant and the review back, and I pass. So no problem to say I don't know. Okay.
Okay,
And even
thank you. Thank you, doctor.
Discussion, I think he asked me in the case of the patient of fibroid and large fibroid and came sick for the fertility issue. The examiner asking me about percentage of something I didn't remember now. I said to him, I don't know. I don't know the percentage, but I replied all the question, and in the last, I think he wanted to give me a full mark or something like that. So he asked me specific about this percentage, and I said, I don't know. The examiner smile and say me no problem at all, no problem. Okay, so it is not a big thing or a big or a shame to say I don't know. No problem if you don't know. And they said I will check. This will be considered patient safety.
Thank you, doctor.
Welcome. Okay. So,
Dr. Ali,
Dr. Hussam, how are you? I'm waiting you.
I want to ask I wanted to ask about the slide which mentions the criteria for cyst referral. It mentions the criteria those first or second degree either with ovarian cancer or breast cancer less than 50 years and 60 years. The third one, it's written another ovarian cancer at any age. I don't understand this point. Another ovarian cancer in the same patient, yani, or what? I don't know what's meant by another ovarian cancer at any age.
Another ovarian cancer.
The patient had ovarian cancer and she had staging cytotoxin. From where it comes another ovarian cancer?
Another ovarian cancer at any age. This one.
What's meant? And the important question, I know it's a sort of question. I know that bilateral, as you mentioned, that bilateral, we can say this relatives or daughters of this lady to geneticist to see if they are at risk of mutated gene BRCA1 and BRCA2, they will receive prophylactic or prophylactic bilateral mastectomy because it's reduced by 90 to 95% of cancer. Delta for this period, if the patient is proved cancer or
your connection is bad, Dr. Hussein. Can you check your connection, please, to hear you good?
Yeah, good. Hello? Hello?
Hello? Yes,
Hello?
yes, yes.
I want to ask, يعني, I know that in advance that bilateral removal of ovaries will reduce the incidence of breast cancer by 50%. And the prophylactic bilateral mastectomy will reduce the incidence of breast cancer by about 90. Improve the ovarian cancer. Okay.
Yes, yes.
Do we appear here for to genetist to detect if gene mutation or not to have another operation bilateral mastectomy or not?
You may. I think you may. I was about to write this for the patient itself to send for the genetic specialist to search for or to do for the cancer gene like BRCA1 and the BRCA2 and the hereditary non-polyposis cancer colon. You may refer the patient itself may be referred to the genetic specialist. Also, her daughter need to be referred sure for the genetic specialist, and the patient also may be referred to check for that.
Okay,
Dr. Ali,
okay. This is what I wanted to ask about. And what's about another cancer, ovarian cancer at any
ICT
age?
may explain or may want to say if the patient has any cancer before at any age of life, like if she had now she is 60, at 40 she has ovarian cancer and removed it before. I think like that. And this is from the get through book, and he write there the reference for that genetic screening.
Okay.
Okay.
can I ask a question, Dr. Ali?
Yes, Dr. Samreen.
Yes, Dr. Ali. So, regarding the referral for the genetic testing, I think that once her genetic, her cancer is confirmed, only then we can refer. If after the surgery histopathology will show up with a low risk, no need to refer. And once it after the surgery histopathology comes to be a high risk and the or diagnosed cancer, then I think she will be referred for the genetic testing for her daughter as well.
For her daughter, if the histopathology confirmed that she has a cancer.
Yes.
Yes, yeah. So after the surgery of her, if she has ovarian cancer.
Yes, it depends on the result of the surgery. Yes, agreed.
Yes, okay.
And also coming back to the risk malignancy index, we can also say that we have a specific tool through which we can calculate the risk of cancer. So in your case, you are at moderate risk. So that's why we have because she's 20% risk, right? So she can be
Yes,
offered
20%.
as a laparoscopic surgeries
Yes.
according to the guideline. So low
Yes,
risk,
according to the
moderate,
guideline,
and high risk.
laparoscopic. Yes, laparoscopic surgery.
Yeah. Thank you.
Okay. I want to share with us.
Me, sir.
Okay, yeah, go on to Dr. Antsar. Okay, I will adjust 2 minutes for Dr. Ansar. Start. Okay, I will adjust the 10-minute start.
Hello, I am Intisar Abdul Qadir, one of the doctors in the gynae clinic today. May I confirm your name and age, please?
My name is Sarah Adam, and I'm 30 years.
How would you like to call you?
Sarah, fine.
Okay. I'm sorry, Sarah, that our consultant is not here today because he is sick, and I'm here instead of him to answer all your concerns. Are you agree with me?
Okay, no problem.
Okay, Sarah. Can I know how I help you? I will help you today.
Yes, I am very worried today, doctor. I wanted to test it for this cancer gene. My mom has diagnosed recently by that she has ovarian cancer, and she did a surgery for that. So I am afraid that I may have that one also.
Oh, I'm sorry to hear that about your mom. And how she is doing nowadays?
It's fine now after the surgery.
Okay. So Sarah, please, if you allow me, I want to ask a couple of questions before addressing your concerns. Can I?
Okay.
Do you have children, Sarah?
Yes, I have two children. I give them vaginal.
Okay. Do you use any contraception now?
No,
Okay. Do you have any medical problem that you see your GP for or receiving treatment for?
no,
Do you perform any surgery before?
no at all.
Okay. Do you smoke, Sarah?
No,
Okay. Or drinking alcohol
no,
or any recreational drugs?
no at all.
Okay. So, what are you doing for a living, Sarah?
I'm a housewife
Okay. With whom are you living?
with my partner.
Okay. Is there any concern about you are safe at home? Sorry, you are satisfied at home? None.
Yes, my partner love me too much.
Okay. Good to hear that. All right. Are you updated with your cervical screening?
Yes, it's up to date and normal.
Okay. Do you use any contraception now?
No,
Okay. Do you have any past history of concern?
no at all.
Okay. Do you have any blood clotting before in your legs or anywhere?
No, but my sister have one.
Okay. Do you know your body mass index or height weight ratio?
Yes, my weight is 20. My body mass index 26.
Okay. Do you have any family history of cancer? I'm sorry, about your mom, your aunt, or your sisters?
No, no at all. Only my mom.
Okay. I'm sorry. Hear that. Hope that your mom to be in good health and wealth after that.
Thank you.
Coming to your concerns, Sarah. Okay. There are. I'm sure that you are right to ask to be worried about your health and to ask about cancer genes. Do you have any background about cancer genes? Or do you read in anywhere
Yes,
or
I read
on
about
net?
that. Yes, I read about that in the net, and I know that it may run in family, and also I may have, and my daughter after that may have, my sister may have. So I am very worried about that.
Is your mom have her mother has cancer or some your grandma? Have cancer,
No,
have
not.
ovarian cancer, or cancer in breast, or cancer in womb?
No at all.
Any colonic cancer or any chronic colonic disease?
No at all.
Okay. Understand that. Thank you for sharing, of course, that information with me. And coming to your concern, of course, there are certain genes that run in family that will address the senses to seek for it if the cancer comes in family. That is to say, your mom, your sister, or your aunt, first-degree relatives have cancer, specifically cancer colon, cancer ovary, cancer breast, and cancer on the womb. Because there are certain families that sharing those cancer genes will have either of those cancers in one of their members of family. So if you want, but from your history, actually, it is that your mom is the only one in family, specifically first-degree relative, that have that cancer, which is decreasing the incidence that you have those cancer genes. But in order to address your worries, we can do it. We can do those genes, which are called BRCA1 gene and BRCA2 gene. Are you following me, Sarah?
Yes, I'm following you. So you will offer me the test.
No, if you, I want to offer you the test if you insist in order to do it, because this will relieve your worries. But in your condition, because I can't see any history of cancer in your family, whether breast or cancer colon or cancer womb, I think that you have a little incidence of having those genes in your blood.
But my mom
And
has this
I
cancer.
prefer. Yeah, I know. And I prefer that I will refer you to a genetic counselor in order to give you more information about that. And I told you that I will offer you, if you wanted to really if this will address your worries, to check if they are present in your blood or not.
Okay.
Are you convinced, or maybe I am a little bit judgmental to you, Sarah?
No at all, doctor. So if the genetic counselor find that I have, will I have this surgery?
Yeah, if we detect the BRCA cancer gene 1 specifically, because the incidence of cancer ovary with it is high, more than BRCA cancer gene 2. So after because you are 30 years now, and maybe you still want to have children, but if you have completing your children, we could offer you removal of both ovaries at the age of menopause. When you're reaching menopause, and before reaching menopause, we will address you close observation and close follow-up by transvaginal ultrasound, for example, yearly. And of course, if you're developing any symptoms suggestive of development of or that there is something wrong in your pelvis, you can come.
Okay.
So we will follow up you until you're reaching menopause, and then we will offer you bilateral laparoscopic bilateral saprophyrectomy.
Okay.
So anything that we will give you a written information about the cancer ovary and about the red flag signs, or what we call the warning signs, that if you develop it, you have to seek medical advice at once. Like, for example, repeated bloating, repeated diarrhea, or for example, losing weight, loss of appetite, and abdominal swelling. All these symptoms we will address. If it happens, you have to seek medical advice at once.
Okay.
And then also, as told you, we could perform transvaginal ultrasound yearly as a part of your follow-up. and maybe we will, and if something goes wrong, we will do all the investigation and even tumor markers to ensure that there nothing going on.
Time finish. Okay, can complete in 1 minute. Okay.
Okay. So,
Any
do you
other
have
thing?
any concerns, Sarah? Do you have any question you still wanted to ask?
No, doctor. You mentioned all of the question I have. So if I didn't complete my family and you offer me this surgery, what I will do? What is my option?
Do you want it to? It is your choice, of course, Sarah. If you don't want it to complete your family and you want to perform surgery, if we detect this gene and you want to perform it now, of course, will be your choice. So I will, if you wanted to do it, I will give you a hormone replacement therapy in order to cover that area because you are still 30 years.
Okay.
And if you wanted any, of course, if you if you're regretting that and you want to have I'm sorry, to have children, you have the option of adoption or surrogacy.
Okay.
So it is my moral duty is to explain everything to you and the pros and cons of everything, and it is at the end it will be your choice.
Okay. Will I have to remove my breast if I have this surgery?
No, if you remove actually your breast, because we will remove the source of the hormones to which the breast is really sensitive, so we couldn't resort to breast removal, but we will give you a close follow-up for breast through yearly mammography, yearly bilateral mammography and ultrasound examination.
Okay.
And if something's going on and we detect anything in the breast, we will take a biopsy, a needle biopsy to examine to ensure there is no cancer in it.
Okay.
But just the mere removal of both ovaries decreases the incidence of developing cancer breast really very much. Okay, with you,
doctor.
Sarah?
Yes. Yes.
Thank you, Sarah, for your time.
Thank you. Thank you, doctor. Thank you, Dr. Antsar. Well done. I know this is also a difficult station, but you did it in a good way, and your communication with the patient very good, Dr. Antsar. Really, your negotiation and your communication with the patient, your sympathy when the patient told you that her mom has a history of breast cancer, your sympathy was very fine. So your communication will be very good. This scenario need applied clinical knowledge, need a strong applied clinical knowledge from the TOG article about risk reducing surgery for the ovarian cancer. So regarding to the comment, you did it in a good way. Your communication was fine. Your situation awareness about the consultant sick leave, so very good from you. And the situation awareness, checking the purpose and asking an open question, very good, very good to say that whether you say what is written there in the task or to ask open question. How can I be of help today? How can I help you today? Like that. Putting the agenda also was very fine from you, and analysis of the complaint regarding to the history taking was good. You ask about her mom, but you forget to ask about her. You can ask her about whether she feel any symptom, any bloating, any diarrhea, any mass, any change in her bowel, like that. Any loss of weight, loss of appetite. Also, this will be good from you if you ask about that. Whether she if follow the breast screening program, she examine her breast regularly for any change in the contour, any lump, any charge. Also, it will be good if you mention that in the analysis of the complaint or history of the present illness. Regarding to the obstetric, you ask about the children, the daughter, but you didn't ask about whether she complete from the start. I know that you ask later, and you mentioned that in the consultation, did she complete her family or no? But take care to forget this very important point, because your management will be totally different if the patient complete her family or didn't complete her family. So it will be considered patient safety to ask about whether the patient complete her family or no. Asking about contraception, very good to ask about the contraception, because as you know, using the oral combined contraception will be protective if the patient use contraception or no. And the patient may ask, may say no or yes according to her situation. Cervical smear also a safety point for this patient, and you did. Regarding to the all the remaining history will be verifying social, medical history, drug, and the family history. In the family history, I think you waste a lot of time, 1 to 2 minutes, to ask about the family history. You can ask open question like any cancer, any cancer in the families at all. You wanted to tell me like cancer, ovary, breast, colon, and you finish. Any clot in your family, you finish. Don't waste your time to repeat the question and to ask a closed question. Ask open question and finish the story. Then you didn't examine me, and this will be a part of the information gathering. You can offer examination in the presence of chaperone after taking the consent. This will be considered also as information gathering. Coming to her concern today, there is will be a debate. This, according to your knowledge from the guideline, from the TOG article, this patient, her mom has ovarian cancer, so her mom may be tested for this, may be tested for that, for the cancer gene. You may ask whether she tested before for this cancer gene or no, because the risk will be totally different if there is a family member affected and there is a risk of hereditary cancer gene, or no risk of hereditary cancer gene. So if the hair of the mom tested or no, it will be totally different for the patient consultation. So you may ask about your mom tested for this cancer gene. She may say yes or she may say no. And if it's tested, it is positive or negative, and for which gene. So this will be also considered from applied knowledge, and they will change in the consultation after that. So regarding this patient, you may ask whether her mom tested for the cancer gene or no. Her mom not tested, so may offer her mom testing for the cancer gene, and if her mom positive and if her mom negative. If her mom is negative for this cancer gene, the risk of the patient will be very low. As you said, your risk will be very low, about 4 to 5% only, against the background about 1 in 70 women. So you can explain for her that the risk of the background, the lifetime risk is about 1 in 70. And if your mom tested positive for that, your risk will be 4 to 5%. Your also risk is still low. So by some lifestyle changes, keep your weight in the ideal, and using combined contraceptive, if she doesn't want to have a child right now, it will be protective for her. But if her mom is positive for this cancer gene, her risk will shot up. The risk will be 30 to 50%, 13 to 50%. Okay, so at that time she may be offered the surgery at all. From the TOC guidelines, they didn't recommend the screening of the BRCA1 and BRCA2 a lot. They, if the patient has a high risk, they offer for her the surgery. But if the patient refuses the surgery, they may offer this testing for the cancer gene. Okay, so if the patient refuses the surgery at that time, we may offer you the testing for the BRCA1 and the BRCA2 and the hereditary non-bulbous cancer colon, and your management will be according to your test. This is regarding to the management option of this patient. Also, if she has any sister, she need to be tested if her mom also positive for this cancer gene. This regarding to the comment, I wanted to tell you, Dr. Intisar, about that one. If the patient didn't complete her family and she asks you about her future fertility, you may offer her embryo freezing and surrogacy. Embryo freezing and surrogacy if we remove the womb for this patient, if she, for example, if she has hereditary non-bulbous cancer. So let's go to the suggested mode of answer for all of us to know what can be done for this patient. As Dr. Ansar did, communication was very fine from here. I'm Dr. Ansar, one of the senior doctors in the clinic. May you confirm your name and age? She says, Sarah, 30 years. Hello, Sarah. My consultant is in sick leave. Can I continue the consultation on behalf of him? She will say, sure. She will say yes. Okay. Understand that you are here today to be tested for the cancer gene. Am I right? She will say yes. Or you can ask, how can I be of help today? This is an open question. I also understand that your mom diagnosed with this. Am I right? You will say yes. Here you can show some sympathy. Very important. I'm so sorry for that. How she is right now? She will say fine after surgery. She is fine now. Okay. Before we discuss the best management plan and what can done for you, can I ask you some question to know more about you? Okay. Go through your template. Analysis of the complaint. How is your mom now? How is your mom now? This is wrong. Okay. And what was her age when diagnosed with this cancer? Any treatment to offer for her? She would say yes, offer surgery. And whether she tested for this cancer gene, she would say no. And you, the patient, do you have any pain in your tummy, any loss of weight, any loss of appetite? Do you share in the breast screening program? If she said no, you have to put stress on that. You have to examine your breast regularly, and if you have any discharge or change in the contour or lump, you should seek an urgent medical advice. Obstetric history, very important to check whether she has a daughter and she complete her family or no. She didn't complete still her family. She wanted to have more to children. Okay, so the consultation will be different. So gynecological history ask about the period and the contraception. If this patient receive or take combined oral contraceptive pill, you can here put some emphasis on the combined oral contraceptive as it is a protective from the ovarian cancer. Ask about the cervical smear, also a safety point is very important. Go through the remaining history, medical, surgical, and any drug, any allergies, also psychological history, because this patient is worried also to ask about the mental health. Family history is very important. And she asked open question about any cancer in the womb, breast, any clot in her family. Her sister may have DVT. Okay, so when you offer her, if this patient offer HRT, you may offer her the patch, may be suitable for her to decrease the risk to have a clot also. So, Sarah, I want to examine you. The examination very important in the presence of chaperone after taking consent, and this for blood pressure, pulse, blood pressure, temperature, for your tummy, for any pain, any mass. Coming to the main consultation, Sarah, having ovarian cancer may happen about 1 in 17 in the woman at any point of their life, and this risk is increased if they have a family history, especially if this family member tested positive for this cancer gene, as some of these genes may run in family, and this is called the hereditary cancer syndrome. So we need to test your mom. We may offer her testing for her mom for some cancer gene like BRCA1, BRCA2, and hereditary non-bulbosis cancer core. If she is negative for this cancer gene, so at that time we don't recommend to do screening for you, as your risk is about 4 to 5 out of 100. It's low. Only some lifestyle measures. Can you mute yourself? Dr. Hussam, mute yourself, please. Thank you. Okay, only some lifestyle measure may be helpful and protecting for you from this cancer, like you keep your weight in the ideal range and continue on the combined contraceptive if she doesn't want to have a baby right now. But if your mom positive for that cancer gene, at that time your risk is about 13 to 50 out of 100, high. So the research is recommended that we offer you a surgery where we will remove your tubes and your ovary to reduce that risk. If she refuse the surgery, at that time you may be offered the referral to the genetic counselor, who may offer you screening for this cancer gene, and your management will be according to each one. The BRCA1 put the patient at risk to have 35 to 45 risk to have this cancer. So we will offer her a surgery at the age of 35. Removal of both tubes and over laparoscopic bilateral saphenophractomy. BRCA2 put the patient at risk 13 to 23% to have this cancer. So we offer her the surgery, but we can delay the surgery to the age of 45. Hereditary non-bulbosis cancer colon put the patient at risk 3 to 13%. But at that type of the surgery, we will offer the patient surgery. But this type of the surgery will add hysterectomy because this type of the gene also may lead to cancer endometrium. If you are negative for these genes, only some lifestyle measures can be protective for you, like as we said before, the ideal weight and continuing using combined oral contraceptive pills. Also, your sister may need to be offered screening for this cancer gene. So you can explain for her the surgery. What will the surgery involve? This surgery can be done by K-health surgery, where telescope containing camera introduced to your tummy under general anesthesia, where you will be asleep, to remove the tubes and ovary. You will be given a patient information leaflet and the consent to sign before the surgery, because like in other surgery, you may have a complication like injury to the bowel, bladder, ureter. You may have blood transfusion. Do you have any concern regarding the blood transfusion? She will say no. Okay. Also, we may find a cancer at the time of the surgery. This is called an occult cancer. Okay, about the percentage is about 4 to 8 out of 100, and you may need another surgery. Also, you have to sign the consent for that. This surgery will reduce your risk to have ovarian cancer about 96 out of 100, but not eliminate it, because there is a residual about 4 maybe present in the surrounding 4%. After removal of your ovary, there is very important to mention that the need for the HRT. After removal of the ovary, there will be a drop of your hormone secreted by the ovary, which is very important to keep your bone strong and prevent the menopausal symptoms as hot flashes, and keep your mental health, sexual health. So this is how to counsel the patient about the HRT. After removal of the ovaries, there will be a drop of the hormone secreted by it, and it is very important to keep your bone strong, prevent menopausal symptoms like hot flashes, keep your mental and your sexual health. So you will be referred to the menopausal clinic to discuss with you the suitable HRT. You may say only that I will refer you to the menopausal clinic to discuss with you the suitable form of the HRT. As this patient has a family history of clot like her sister, so the patch may be the suitable option for her. She may ask you, I have served the web and I heard about a protein called the CA125. It will be helpful in my case. CA125, according to this the TOG guideline, the TOG article, they offer to the patient pre-operative. If we decide now to do the surgery for the patient, we'll do the CA125 and the transvaginal ultrasound to see whether this patient has susceptibility of the ovarian cancer or no. So, Sarah, this protein may be elevated in half of the woman with ovarian cancer, but may rise also in another sinister cell and another non-sinister cell. So we don't recommend to do this unless for the woman before surgery with a vaginal ultrasound to evaluate the presence of ovarian cancer, as there is risk to have ovarian cancer at the time of the surgery about 4 to 8 out of 100. Okay, what if I didn't complete my family before the surgery, doctor? Okay, if you have a stable partner, we may do perio-freezing. And if we remove your womb, you may be offered the surrogacy after that. Do I need to remove my breast after remove my ovary? The lifetime risk of if you tested positive for the BRCA gene will be high, but removing the ovary will halve the risk for that. You will be at least advised to follow your screening program, like Dr. Antasar said. You may be offered non-hormonal option. You may be offered the HRT till the age of the 51. This all to decrease the risk of breast cancer. You may be offered the hysterectomy, and after that you will be offered the estrogen alone as HRT. You may be offered the prophylactic mastectomy. All this option written there in the TOG article. Any questions so far? She said no. I will give you now the patient information leaflet, arrange another meeting with my consultant, and give you contact number. Any question?
Thank you, Dr. Ali, allowing me this opportunity, sir. Thank you.
Thank you, Dr. Welcome. You did very well. Thank you. Okay.
Hello?
Thank you for all of you.
Hello?
Dr. Hussam.
But I wanted to add some point. I noticed that in every history taken in cases of cancer ovary and the cancer breast, we don't stress about asking about the breastfeeding. Breastfeeding itself proved to decrease the risk of cancer breast. For 1 year, breastfeeding reduces the risk of cancer breast by 4.3%. And as for ovarian cancer, breastfeeding for 31 months reduces ovarian cancer by 91%. So that I think we should ask about if the patient breastfed her children or not.
Good. Good, Dr. Hassan. Good point from you. Any
Thanks,
other point you want to add? Welcome. Thank you for all of you. Thank you for all my colleagues. Inshallah, see you in the next session. I hope that you are doing your best. Inshallah, all of you will pass the exam. The exam is very easy, but want to do hard. You don't waste your time. Study with your study partner. Apply, revise the guidelines, the talk, the nice. Okay, read the patient information every day. It will be improve your communication with the patient. And thank you for your time. See you inshallah soon.
Dr.
Thank
Ali,
you,
I
Dr.
have,
Ali. Thank you.
Thank you, Dr. Ansar. Thank
Dr.
you.
Ali, I have a request.
Yes, Dr. Samarin, yes, I'm with you.
So Dr. Ali, if we can have another session about cervical screening and HPV management of cervical cancers as well, along with the vulval with lichen sclerosis, and we can have another session of oncology, so that will be very great.
Okay, inshallah, I will arrange it, Dr. Samarin. Okay.
And coming back to Dr. Ali, in this scenario, like Dr. Intisar has done very well. So as you mentioned that take history and inquire if she is having some problems currently. So from the breast, we can inquire about the any discharge or any lump or any mass, and then protective factor as well for the breastfeeding as well. And she's following breast screening program as well. And she's also herself testing, checking her breast. So and if she's doing, reinforce that and give her like this is a very good point, and you can be diagnosed earlier. And then coming to the ovaries, ovulation induction. So conception will be inquired, like these two pregnancies which you are having. Is a natural conception, or you have a history of ovulation induction, because that ovulation induction is the increasing the risk factors. And if she is using contraceptive, this is a protective factor. So both things side by side. And then in the cancer, smoking, multiple partners, and following the screening program, smears, all these things will be protective things as well, increasing factors, while condoms will be increasing risk factors. As she is not using the contraceptive, so this will be advisable. Coming to the endometrial protection, so weight is very important. If she's on a higher side, lifestyle modification will be protective. And if she's taking any HRT or any herbal therapies or anything, that should be also inquired, so to reduce the risk factors for the endometrial cancers, along with the menstrual history like diabetes and ovulation, like polycystic ovaries. So this is also increases the risk of endometrial cancers. So she can be offered like reduce your weight and lifestyle modification. That's how you can prevent all these things naturally. However, if you notice any of these changes, you can come back and we will definitely screen that and follow those programs. I think that will be
very good. Very good. Very good. Add most valuable information for us. I can add this information. So thank you very much. And if you have any other information, if you have any other point, we can discuss in the group. Okay, we have our group steps in the Telegram and in the Facebook. We can discuss if you have any query, if you have any point you wanted to add in the task. It will be very informative for me. Thank you.
Thank you. Thank you. You're welcome.
Inshallah, see you soon, inshallah.